So, hello everybody. My title today will be, can AF cases be accelerated with radio frequency? What's the role of very high power, short duration? And I have a picture of Formula One there. I know that ecologically this is not really correct, but I will show you afterwards why I have this. This is a disclaimer, my conflict of interest. So we know from the guidelines that AFib is endemic in EMEA and that the risk is increasing strongly with age. We know that with COVID, we had really long waiting lists, like you can see here on Mount Everest. We have this epidemic coming on, and if we really believe that we can help these patients, we should do something about our efficiency. And that's why you see everywhere now meetings about efficiency for ablation. If we look at the guidelines, everybody, if we think about which patient should we treat, everybody has this young patient, this sporty patient in his head. But if you look at on this slide, the patient that is the sickest is the only class 1 indication. So we should have this mind shift. I think that the patients that are the sickest, the elderly patients with heart failure, they benefit most. This is a class 1 indication. First line, even without taking any drugs before. So this should really change our mindsets, I think. Of course, we know the other settings. Most of us still consider this for symptomatic relief, but I will show you in my next slide that I think this is wrong, that we should open our mindset for that. New in the guidelines is as well that we can really confirm this. I already ablated patients only based on a smartwatch device with atrial fibrillation. In the guidelines, it's written that the cardiologist should still confirm the diagnosis, but it is a valid, we don't need a 12-lead ECG for the ablation. What about the pill in the pocket, NOACs? This was a big discussion on the last ESC Congress. I think this will be discussed next year with 2 studies going on. The follow-up with wearables and implanted loop recorders is something really exciting, and then we will really see objective data on how good we are. I want to discuss 3 myths if we talk about AFib ablation. First of all, I just showed you already, even the guidelines say that we are wrong there. So AFib ablation is not only for the young and healthy patients. On the contrary, the patients that are sick benefit most. AFib ablation is dangerous above 75 years. I will show you some. We only have registry data because they're mostly expelled from all the randomized trials. But I will show you multiple data that the complication rate is the same. Obesity is higher with complications, but not age. And it is not only for symptom control. So you can see that here. We discussed most of these points already based on Castle AF, on Cabana sub-studies, EastAF net sub-studies. I think that the next guidelines, but maybe Tilianos knows more about this, will also incorporate asymptomatic atrial fibrillation as an indication for ablation. We can see this. This is, for example, a circulation editorial from Hugh Calkins. Should we treat patients with asymptomatic atrial fibrillation? And he's saying, and he's quite conservative still, I find, if I were 50 years old and I had asymptomatic atrial fibrillation, there's no way I'd want to have AFib for the rest of my life. If we look at the most important study for atrial fibrillation for the moment is the EastAF4. They could have chosen a nicer title, I think, but it's still the most important study. In this study, 30% of the patients had persistent atrial fibrillation and 30% of them were asymptomatic. So keep this in mind. Also Lucerne, we also participated in that trial. It was difficult to get patients randomized, so that's why also asymptomatic patients were included in that trial. But that's why it is, I think, even in that group, it is beneficial for asymptomatic patients. If you look at the guidelines for persistent atrial fibrillation, you should perform a cardioversion and really check if they're truly asymptomatic, because many of those patients are not asymptomatic. They will say afterwards that they are better. It's a common thing that humans, if they have a chronic disorder, that they will get used to this. So really bear this in mind. So the latest trials that I wanted to show you from the ESC in Barcelona, we have the eBrave AFib study. So this was not like the loop study. This was positive that they said we have clinically relevant events if we use a smartphone for detection. Then we have the CAPLA trial that said we do PVI or PVI posterior wall isolation. There was no difference between both groups. A really interesting thing, and we will discuss this in the AFib symposium this year as well, is I think it's because of RF, maybe with PFA and the posterior wall, there will be a difference, but we don't know that yet. Every study that comes out with heart failure is all positive, even prognostically. So my colleagues of invasive cardiology, they're really jealous. They tell me all our studies are negative more and more. All your studies are positive. The sky is the limit. Just show you briefly Invictus, but I think rheumatic heart disease, I don't know how frequent this is in Greece. In Switzerland, it is not. But of course, we can see that NOACs are not better for everything. They can be worse. This is the market analysis that I asked Biosense Webster for me to make. And we can see that from all the patients in Switzerland, 4.5% of them are finally treated with an atrial fibrillation ablation. And that is the benchmark. And I think worldwide, it's around 4 or 5% as well. In Lucerne, we have 9%. So according to them, we are high above the benchmark. And I think it's mostly because of safety. If you are safe and you have good results, the patients start even asking their doctors to be referred. If we look at the age distribution of ablation to go to the next myth, in Switzerland, you can see that 27.5%, and this is already an old slide, it's even worse now or better, are patients above 70 that get ablations, not only AFib, but all kinds of ablations. If we look at complications, there are 3 studies that analyze this. They're not big studies, not in circulation, but this is the best we have. They all show every time the same thing. Age is not a complication risk factor, obesity is. Also for AFib ablation, all the studies we have, they all show there's no difference in complications above 75 years, for example. The Dunning-Kruger effect, this guy, he found on the internet that if you use some lemon juice on ink, that you can make the ink disappear. So he put this on his face, he was robbing a bank, and 2 minutes later, of course, he was caught by the police. I will show you afterwards why I show this slide. So this is a big discussion. It's also one of the topics on the sessions we will have during the AFib Symposium of Biosense in March. We will have a meeting there because I will organize that meeting together with Philipp Sommer and Eva Svenberg about versatility versus simplicity. And I think this is really important, this question, are they still competitive to each other? We all have these new technologies, PFA, single shot devices, and I strongly believe that RF, and I hope you're also convinced after my talk, will clearly has its place for the future. Of course, the downside is the learning curve is clearly longer. Reproducibility is there if you use the closed protocol. It is safe in good hands. Effectiveness, I still think, and everybody will say we have these randomized trials, but there is a selection bias there. If you ask the perfect performance from RF ablation like Matthias Datschav, he refuses to use single shot. If you ask the big single shot centers and they have some RF done by the fellows, we will never have a good randomized trial there, I think. Radiation is a big issue still. I hope that some of these PFA systems will have 3D mapping system inclusion, but they don't have it yet. And the most important thing, if you think about the patient, is if they have different arrhythmias. And in my lab, 20 to 30% of my AFib patients also have CTI needed. Then, of course, you need a catheter where you can do this. The procedure times in my lab with the Q-dot catheter is 55 minutes on the mean time. And with FarWave that we also have, we have 45 minutes. So we talk about 10 minutes difference between these 2 technologies, but changing times of 60 minutes. So what are we talking about? These are the data that we have from Frankfurt. They're also quite innovative. High volume centers, you can see both single shot devices, but their times with the cryoablation is much longer, 70 minutes compared to, for example, Farapulse. So single shot and single shot is not the same. It's even longer than our cases with point by point. I will not discuss this too long, but of course, I'm a big fan of the closed protocol, the Vstack trial. We also participated. We want to have these lesions with ablation index close to each other. We will discuss the peanut shape afterwards. But of course, in the beginning phase, it was too long. The procedures were taking 2.5 hours, 3 hours. So we needed to do something about that. And that's where we started using some efficiency management that I will show you after this slide. Some words on the circle size, because this discussion comes up everywhere that we give talks. And I discussed this as well with Matthias, because I told them that you probably would ask me. So we have on the left, Richard Schilling that did osteal ablation with really small circles, not isolating the carina. This is of course a problem. First pass isolation, 90% there. Clearly inferior clinical outcome, which makes sense because the thickest tissue is on the carina. Then we have the peanut that, in my opinion, is the best strategy to follow today with this technology. I don't know in the future. We there leave the backbone bundle intact. We ablate the thick PV sleeves with the Q-dot catheter. And I think this is important. If you make WACAs and you don't have these microelectrodes with the big PV sleeves, you can clearly leave epicardial connections. And this is why I think in all these studies, they have clearly lower success rates than in my lab or in Matthias' lab or in Helmut's lab. And this is because of this peanut. Of course, people say you don't ablate the ganglia. One of the questions that pops up for me is I don't know if a WACA done with RF is the same as a WACA done with PFA. And I think this will be exciting new studies in the future. And as we showed already, the Kaplan trial was negative. I'm not sure that it would be negative with PFA because it's a completely different kind of ablation. So there's no randomized trial between the peanut shape of closed protocol and WACA. So if you tell me that we all have to do WACA, you have to convince me. If we then look at these lean strategies, I showed this, I think, last year in Thessaloniki, so I will not talk too much about this. It's really easy, refers to simplification. You need to standardize your procedures to be safe. If I'm tired, my nurses, they know what I want. They give me the next material, and that will really decrease your complications. So first simplification, same catheter, single groin puncture. I also believe that for standardization, you still need to use general anesthesia if you want to make stable lesions with RF. I know that this is not always easy in Greece. High power, short duration for me has clearly role in efficient procedures. I will show you later also some really short procedure times, not only for my lab. We now use the QuickClot for closure, and we always use ultrasound-guided groin punctures now. I know everybody can do this, but this should not be a testosterone question. You should think about your female patients with bleeding afterward on the ward. We also know from COVID that we're really bad in being flexible and adaptive. So we always take first come, first serve. We have really long waiting lists, and we should be more agile there. We should really think about, we want to keep our patient in sinus rhythm. It's not just about the ablation, it's everything around. It's about the medication, it's about these lifestyle changes. It always sounds boring, but it's the only way that we can get success, and we should really change. So we need both lean management and agile management. So we wrote an editorial about this. I truly believe that, oh, sorry, I don't know what happened with that slide, that we need general anesthesia for stable lesions, especially we use now with the Q-dot catheter a new algorithm in extended evaluation. And I think it's almost impossible if you really want really stable contact to do this with local anesthesia. Some of my colleagues, like also Daniel Scher, says he can do this, but he doesn't have this new algorithm. You need to do one of the two things. You should make your interlesion distance smaller, I think, or you should keep it the same way, but then you have to use general anesthesia because you will be more stable with the steerable sheet and with general anesthesia. So in the beginning, I didn't like to use the Visigo sheet because we are all the same. We use the technology we know. But then I asked, because I'm really data-driven, my clinical support, just give me the data with Python, show me my stability, my contact force. And it turned out, objectively, that I was doing better, slightly better with the Visigo sheet. So we changed completely, and it's the only sheet we still use today. There's a paper from Osorio that says that it is clearly superior. I think the big message is use a steerable sheet, not which one you use. That's my honest opinion. So the Q-dot catheter, we have this now since 3 years. We did almost 1,200 cases with it. So we're, I think, in the top 5 worldwide. And I really like this catheter. So you have the micro electrodes to look at the micro signals. And this is important for me. I really want to see where are the PV sleeves the thickest. And then I will ablate them, but not too deep into the vein. But clearly, I still want to see the signals. On the other hand, we have feedback. I know it's not from within the tissue, but at least it's the best we have from the tissue that we are heating the tissue, and it really changed my ablation strategy. So now I go deeper into the vein on the ridge, for example. I turn more in the left superior vein, and I have some really good heating there. And in the beginning, I was really ablating, like everybody, I think, on that ridge lower, making smaller lesions. So this is how it works. So you have some temperature feedback, irrigation feedback, and power drops, and it is clearly safer. We almost never encounter steam pops anymore with this technology. So why is high power hot? Why is this such a big thing next to PFA today? We can have, of course, the biggest reason we want it, the largest reason, is improved efficiency. We can have lesions from 4 seconds. We don't need 10, 15, 20 seconds anymore. We can have more durable lesions. Because of the low irrigation rate, we don't have this problem with the shell anymore. Because in the past, if you have, of course, too much irrigation, you could have some edema on the shell, and you can avoid this with QDOT. And I will show you, and in the beginning, I was really afraid to use it on the posterior wall, and everybody is in the beginning with this catheter, but now I do the opposite. If I know that the esophagus is there, I will put it on 90 watts, and I will show you this with the data from Nakagawa. So what we see is thermal latency. It's something really interesting. We profit from the fact that it's only 4 seconds, but that the ablation is going on for 15 more seconds afterwards. But of course, there are some data. If you have too much contact force, the margin of error is smaller. It's a powerful tool. So these are the data from Nakagawa. The most dangerous lesion that you don't know what is happening is low power, long duration. You can have a difference of depth of 6 millimeters. So you really don't know what you're doing. And on the opposite, the safest lesion with the smallest standard deviation, and I think it's in the next slide. I will go back. Here, if you see on the right side, and I think for me this is really important, the standard deviation between the lesions there, they're all 2-3 millimeters thick, all of them. If you look at low power, low duration, they go from 2 millimeters to 6 millimeters. And this is dangerous because you don't want this lesion difference. And that's why it's really elegant on the dangerous situations, like you can see on the left side here. This was close to the sinus node. In the past, I would go down to 25, 35, but what Nakagawa and Matthias learned me, no, on the contrary, do the opposite. I use 90 watts next to the sinus node, 90 watts next to the AV node, and not 35 anymore, because I know how big my lesions are. Of course, they're a little bit shallower than with the low power, longer duration, but we also know that we don't need thick lesions. So this is this concept of thermal latency. You see that the ablation is for 4 seconds, but 14 seconds later, you're still heating the tissue. And that's why I still use a temperature probe for these cases, not to stop my ablation if I'm having heating, but to go to a different spot. I don't want thermal stacking of the temperature. So I will first ablate on the superior side and then go back to the inferior side. I don't stop my lesion itself, but I use it for my next lesion. So we use the lab optimization tool. We have all these steps. We really believe strongly in standardization. So I can know minute and second precisely how much time I use for my puncture, for my mapping, for my ablation. And then you can see that 50% of the time in my lab, and we have times below 60 minutes, is still used to not treatment time. So we should also improve that. And of course, now we have to talk about closure devices and no use of general anesthesia. So why did I show you this picture of Formula One? I think in my lab, we reached almost the maximum efficiency during the case for RF. But what we did not reach yet is the maximum efficiency for my changing times. And I'm now working on this analysis phase. So with the LOT tool, you can also look at this and you can see that our changing times are around 60 minutes. And we are now, everybody in an agile way. I asked my nurses, I asked the anesthetist, everybody is thinking about the best ways to go down to 30 minutes. And I think that should be my goal. I don't want 60 minutes anymore. I want to go down to 30 minutes. So I want to have the cleaning personnel to come to help me with the change. If the patient is there, maybe with some headsets, no general anesthesia anymore, closure devices, and we can go down to 20, 30 minutes. Some labs still have 1 hour, 1.5 hour, 2 hours changing times. So if you look at the efficiency improvement, why do we use hybrid close today? So we looked at everything. You can see it's highly standardized in my lab. This is since 2.5 years. If we use high power short duration Q mode plus Q mode or hybrid, all the times of the setup are 40 minutes. If you look at the mapping length, they're all the same, 10 minutes. It's really small standard deviations. Validation length. So if you take those two out, 15 minutes of my procedure time, that is 55 minutes, I'm as fast as PFA with the RF catheter, with QDOT, with this high power short duration. And you can see that for me, the most efficient one is hybrid close. We want to make a little bit larger lesions on the anterior side, on the carina, and then the shallower lesions on the posterior wall. So what we do nowadays, Q mode is the 50 watt setting with QDOT, 50 watts everywhere. That's what we were doing completely in the beginning. We'd complete the normal ablation index settings and close protocol. Then we went to phase 2. We did Q mode plus everywhere, 90 watts everywhere. And we saw, even if we were doing 4 millimeters interlesion distances, that we still had lower first pass isolations. And nowadays we use the hybrid close protocol, and we have really high first pass isolation, RF times of 8 minutes, and now the procedure times skin to skin are 55 minutes. So we can really be competitive with single shot devices. These are some data. I will not bore you with this, but just to show you that we have many studies showing that it is safe and effective to use high power short duration from my lab, from German labs in Frankfurt, from Matthias' lab, from everywhere, from Liverpool, from the Dheeraj Gupta, all having good first pass isolations, procedure times ranging from 50 minutes to 100 minutes with high power short duration, with the STSF catheter, with the ST catheter, and the Q-dot catheter. And the close protocol is a standardized protocol. It doesn't matter which catheter you use, it works in every setting. So this is from the Power Plus study that we just submitted to Jackie P. We have, of course, it's 6 months data, but now with new technology, things are going so fast that 12 months you're already old if your data comes out. So you will see more and more papers coming out with 6 months data, and you see no difference. I don't show you here the new algorithm that I'm using in my lab with QMod Plus, the AMT3 algorithm, but we will discuss this during the AFib symposium. Why do I make a voltage map? I truly believe that if you want to have high quality, you should make a voltage map. This is in persistent atrial fibrillation. I always make my map after the PVI in sinus rhythm, and then we will discuss if we go further with Marshall plan or encircling of the low voltage, or we stop the case. Even if you have a persistent patient and you have everything is fibrotic, we can have a discussion to do pace and ablate afterwards. So for me, prognostic, if you want to deliver high quality, make a high density voltage map after your case in sinus rhythm. You see, this was done yesterday, just before I took my plane. The 2 patients I did yesterday before my plane. On top, you see female patients. She is born in 56, atrium 120 milliliters, paroxysmal atrial fibrillation. It's a map in sinus rhythm. The low voltage there is true. It's fibrotic, it's low voltage. I saw it on the Pentray signals. I did in that patient, she clearly had paroxysmal atrial fibrillation. I isolated and not just burned the posterior wall, because you also see that in studies. You really need to pace with 20 milliamps in the middle, and it needs to be isolated. On the bottom, you see a patient in long-standing persistent atrial fibrillation with the left atrium from 146. We ablated the veins, and in sinus rhythm, it looked like on the right side. So this is patient-tailored. This you will never do with the current PFA systems with pulsed field ablation, but I'm convinced that both of my patients, they are treated correctly here. So just shortly, I'm coming to the end. So we use nowadays this AMT3 algorithm. It's a new algorithm that Biosense is developing to have also with QMod Plus some feedback on the quality of your lesions and to see that the 90 watts points are on the correct spot. And if you're really safe, we are now submitting this paper as well. You can use the same catheter, and this is again talking about versatility. We did some cases together with Bern in Switzerland. We want to be efficient, so we combine VT ablation with CTI ablation with PVI ablation in these patients. The complication rate is not going up. The procedure is 20 to 30 minutes longer, and it's all done with the same material and the same cost. So this is, of course, if you have long waiting list, you should make selections. Do you want to be faster with high power short duration or single shot devices? Do you want a faster turnover with closure devices or no use of general anesthesia? Or you want same day discharge to have more patients in the same beds? Or do you want to do less procedures in the same patient, combined EP procedures and versatile cases? So this is a glimpse into the future. Of course, we discussed a lot the Q-dot catheter. We will start the first studies with focal PFA with Biosense in the first quarter of next year. I really think it's fascinating new technology. We have the focal PFAs where you can switch between RF and PFA. You can use them cryo-like, 1 second burn to see if you're on the right spot close to the AV node. And then you can do the real lesion afterwards if you think you're safe. Of course, single shot devices where everybody is talking about. The Heliostar, and it is my opinion, but only my opinion, that cryo will be dead in 5 years. So the Dunning-Kruger effect for physicians, you can all see these electrophysiologists in the beginning. If you're a fellow, you learn from nothing. You have the feeling that you're really confident, you're the best guy on the planet, so peak of Mount Stupid. Then if you start learning more of AFib ablation, You start saying, I will never be able to do this. And then finally, you'll be at this plateau of productivity, 10,000 years. So that was for the first slide that I showed you. On the right side, it looks exactly the same. This is Gardner's hype cycle. So PFA, the question that Ante Anic was asking, will this hype continue? We really don't know. We all can say that we saw the same hype with every technology that came on the market. If it is PFA, if it's single shot, if it's PVAC, if every catheter showed this hype, but we should wait a little bit to really be convinced about this. First data also show we have inadvertent posterior wall isolation in healthy persons, small atria, even if you try to avoid them. Vivek already showed us that you have coronary spasm, that you have transephrenic nerve injury with this technology that was said that would never do this. We clearly see silent emboli and lesion regression as well. So as take home, I still think that RF has a place and will have a place for the next 5 to 10 years, but it needs to be standardized. We need to challenge ourselves and we need to be excellent. PFA will probably take over for simplicity. We don't know if the hype will continue. Every PFA system needs to make its own work. It is not because it's PFA from one company that you immediately have to trust the other company as well. I think that cryo, the ice age is over. Data collection is crucial. Substrate mapping is really important if you want to deliver high quality, in my opinion. Combination of tools, it's not just one magic tool, but it's everything together that you can be really, really good with your hands. And I think finally, offer AFib ablation to your patient. He deserves it. Thank you.
Thank you very much, Benjamin, for this nice presentation. And now, Michael Efraimidis from Center